Hello, everyone, and welcome. Thank you for joining today's webinar, which is the fourth in our series on food, nutrition and dining. My name is Janet Anderson. I am the Aged Care Quality and Safety Commissioner. I'd like to start by acknowledging the traditional owners of the lands on which we're meeting right the way around Australia and paying my respects to elders past and present. I extend those respects to Aboriginal and Torres Strait Islander people who might have joined us for today's webinar. A few housekeeping details to start. But let me commence with the good news that we have established within the Commission a small team dedicated to working on food, nutrition and dining. And this expert team includes dietitians and speech pathologists who are going to help Commission staff by informing, educating and advising them as they go about their regulatory activities, and also ensuring that information is available to the sector, to you as providers, to assist in delivering nutritious, varied, appetising food to aged care consumers that really makes food and eating enjoyable. And indeed, our expert team is going to work alongside our customer contact team to assist in taking calls that we are likely to receive on what we've configured as a hotline, which we are going to be increasingly advertising to the sector, that can be called between 9 and 5 Monday to Friday, Eastern Standard Time, if people have concerns, complaints, queries, or seeking points of clarification on anything relating to food, nutrition or dining. Now, today we're going to be talking about older people's oral and dental health and its impact on eating and nutrition. It's a particularly apt choice of topic given that this week is Dental Health Week, which focuses on the importance of taking steps to care for teeth and gums to help in keeping teeth and providing, as they say, smiles for life. And I'm delighted to be joined today by Melanie Wroth, who is our Chief Clinical Advisor, and 3 oral and dental health professionals, Honorary Professor Janet Wallace from the College of Health, Medicine and Wellbeing, University of Newcastle, Nick Greer, who's a Director, Australian Dental Prosthetists Association, and Dr. Janani Ravichandran, Oral Health Promoter, Australian Dental Association. All right, a few brief words. It almost goes without saying, but is worth repeating, that dental and oral health have a significant impact on our appetite, eating and nutrition. So today, Melanie and our 3 panellists are going to discuss the actions that residential aged care providers can take to support your residents' daily oral health. Now, we've allocated around 60 minutes for this webinar and we will be recording it, and that recording will be available via our website. So please let other people know if they've not been able to join us today. We do want to hear from you as well after the panellists have had a go. There is the provision to submit questions, and I encourage you to do that by clicking on the question mark icon. We'll endeavour to answer as many of your questions as we can in the time we have available, but if there are some left over, we will certainly put information on our website. And before you log off at the end, there is a survey at the end of the webinar. We would really be pleased if you complete it, and it will be submitted to us. Very keen to hear from you. Did it work for you? What could we have done differently or better? We are very determined on continuing to improve the way in which we deliver webinars to you and making sure that they meet your needs as well. 3 public service announcements, if you like, before I hand over to Melanie. First, we have published a suite of resources on oral health, which has been developed through expert input and are available to download from our website. And they do include information about supporting daily oral health, so they are directly relevant to the topic for discussion today. Please make use of them. Go and have a look at them. Download them if you want, but definitely access them and draw on them. We are going to also put them on our online learning platform. Second point, we're very keen, and this is work being led by Dr. Wroth, we're very keen to develop a resource to support and indeed encourage providers to set up consumer-led food focus groups or food committees in your services. So we're very interested in learning how residential services have brought about effective change by having formal and informal consumer involvement in the decisions about food and dining. So many thanks to those of you who've already taken your time to complete our survey on this. But if you would like to submit responses to our survey on this particular issue, you can do that by getting access to the survey on info@agecarequality, or one word, .gov.au. And my third point, which kind of relates to the second, very keen to hear about different models and particularly success stories. So please, if you have done something that has made a difference, a positive difference to the consumer's enjoyment of meals, their nutritional content, the presentation, you're getting some really good feedback from consumers about food, nutrition and the dining experience, let us know. Come to us with that advice, and we are happy to publish it on our website with your agreement and to make it more widely known. All right, that's enough from me. I'm going to hand over to Melanie, who will lead the panellists through a series of questions. Melanie, over to you.
Thanks very much, Janet. I've been really keen to present this webinar topic. As you said, this week is National Dental Health Week, which is promoted by the Australian Dental Association, and the Commission is very pleased to help in raising awareness and sharing information on this topic. Oral health is one of the 4 priority areas identified by the Commission's Food and Nutrition Expert Advisory Group to improve food, nutrition and dining in residential aged care. We've looked at the other 3 areas already: dining, choice and swallowing, in our previous webinars. So this year's theme for Dental Health Week is Mind, Body and Mouth. The health of the mouth is not only important to eating, but also to the overall health of a person. Prioritising good oral hygiene, which is care of the mouth and teeth, helps improve not only the health of your mouth, but also reduces the effects disease within the mouth may have on other chronic conditions. So it's important to know that goes both ways. Other conditions can also have an effect on the mouth. Good oral health and dental health enable you to eat, drink, speak clearly, and smile with confidence. It all has a flow-on effect to a person's quality of life. Having well-functioning dentures is important too, and from time to time we hear from people who've been placed on a puree diet simply because their dentures don't fit. It's not about function only. It is about function, but not only about function. Obviously, well-functioning dentures are really important for dignity and appearance as well, and I can just tell you from personal experience how often I will come to a bedside of a patient in hospital and find them like this, telling me, I'm so sorry, I can't speak properly and I'm embarrassed to be seen without my dentures. So just give that a bit of a thought when you've got people who may not have their dentures in. Given that we, at the Commission of the National Aged Care Regulator, you might well expect that people bring complaints to us about dental and oral health, which they do, but you may not immediately think that we also come to know about dental and oral health concerns through notifications to the Serious Incident Response Scheme. So some examples: incidents have been brought to the attention of services by family members who had observed their loved ones' neglected mouth and teeth care in the form of dirty teeth, foul breath, bleeding gums, or toothbrushes or toothpaste that clearly haven't been used over a period of time, or where there was no access or consideration really given to dental care when it was clearly required. Some incidents were brought to the provider's attention as a result of observations by dentists who identified tooth decay or infection due to poor oral hygiene, with some indicating that such issues could have been avoided with better regular dental care. And services' failures to remove, insert, clean or appropriately store dentures or dental plates, or failure to prompt and assist residents to do these things if they're doing them themselves, has also been noted in some of the CERS notifications under the neglect category. So just pause and think, how do you know that these things are actually being done despite your excellent policies and care plans? How do you know it's actually happening? So we're going to address these kinds of issues in today's webinar. We are going to talk about common oral health problems and what their impacts are on eating and the experience of the consumer. Consider the signs of oral and dental problems. Discuss the role of oral health in nutrition. Explore best practices for good routine oral and dental care, including in a dementia setting, and look at denture care and maintenance. As Janet mentioned earlier, please submit any questions and we'll get to as many as we possibly can. So Janet Wallace, Nick and Janani. It's such a pleasure to have you with us today to talk about oral health, and really, really thank you for making yourself so enthusiastically available. So let's begin. Oral health really does have an impact on the mouth, the body and the mind. When things don't go well, it affects an older person's life by causing discomfort or pain, interrupting sleep, affecting someone's ability to eat, drink and speak. It can also negatively impact how one feels about their appearance, their general health and their quality of life. So Janet, what are some of the common oral health problems you see in your line of work, and how do they affect older people and their quality of life?
Yeah, thanks, Mel. So those conditions that we see are xerostomia, so dry mouth, very common in the elderly population, periodontal disease, gum disease, dental caries, holes in teeth, root caries, candidiasis, thrush, which is also very common in our elderly population, oral cancers, ulcers, abscesses, broken teeth, sharp teeth that are cutting soft tissue, ill-fitting broken dentures and lost dentures. Now, all of those conditions affect the general population as well, but if left untreated in our frail and elderly population, they can have some really devastating effects. And they are that it will impede their ability to eat and to swallow and to chew, leaving them hungry. It can cause behavioural problems, especially in those residents who have any cognitive issues. It can cause ultimately malnutrition, which then leads to weight loss, muscle loss, and also can be a contributing factor to falls. And if the mouth is really unclean and there are open lesions and lots of plaque and debris sitting all around the place, then our residents are at risk of aspiration pneumonia, which can be very devastating and in some cases can result in hospitalisation and also untimely death. So you can see from that list that left untreated, those conditions can really have some very serious impact on the quality of life of our elderly and frail. So oral health professionals need to be providing some services in aged care to ensure that the staff are provided with education so that they can identify these oral health conditions, and ensuring that the residents' mouths and teeth and dentures are cleaned on a regular basis. To be able to provide the facility staff with really solid, valuable oral health information that the carers and staff can then take to the residents to enable them to be able to identify problems. And also, often in our facilities, we have residents who are not able to care for their own oral hygiene. And so having a dental practitioner who's providing some input into the facility too will assist all staff in being able to assist the residents in brushing and cleaning and keeping their mouths and dentures clean. The other thing that's very important in this area is ensuring that the facilities have got policies and procedures and processes in place to ensure that there is a really appropriate oral health standard of care, and ensuring that that's happening on a regular basis. We need to make sure that our residents' oral health care is documented just like all their other daily care needs, such as showering, toileting, medications, etc. We need to ensure that oral health is also part of those daily cares. Thanks, Mel.
Thank you. So Nick, as the Director of the Australian Dental Prosthetists Association, what are some common oral health problems that you see?
Thank you, Mel. No matter what your age, oral health is vital to general health and wellbeing. So from a denture perspective, I'm going to call out three main denture issues associated with oral health problems. So to start with, the fit and the function of dentures. The aesthetics, the appearance indicators, speech, chewing and swallowing, and choking issues. It's not widely known, but dentures generally last 8 to 10 years on average, with those made in the public sector through government schemes a little bit less, about 6 years. So the teeth are plastic and will wear down. impacting aesthetics, which also leads to impacts of function such as chewing. The second one is dentures in need of repair or attention. So chipped or missing teeth, the chipped or broken denture base, the pink part of the denture, the acrylic, a bent or a broken metal wire or a metal clip that holds partial dentures in the mouth. So all of these areas will mean the denture is no longer functioning to its full ability, and therefore the patient can't use it properly, and it impacts their health greatly. The last of the three is dentures that are poorly fitting or lost or missing, which happens a lot in our aged care facilities. Patients do get a little bit forgetful, take their teeth out and pop them in a tissue and forget where they popped them. So oral health problems, particularly in people with fewer than 20 teeth, can be impacted by the location and the spread of the tooth loss, and include irritation and trauma to the gum and the oral tissues associated, overgrowth of oral tissue under the denture, which is something that we see quite a lot as dental prosthetists. Another point here is relines of dentures should occur every 2 years to ensure that they're fitting correctly. So that's changing the fitting surface of a denture to make sure it fits the patient's mouth. The last of the points here is that ulcers and sore spots noticed in the mouth caused by a denture that doesn't fit. So denture should be checked by a dental professional at least every 12 months, or if the patient is noticing things like ulcers, or the staff notice ulcers in the patient's mouth, to have a dental professional check out the patient as soon as possible. Thank you.
Thank you. So we'll come to you now, Janani. You're a dentist and an oral health promoter, and you've had significant experiences working with older Australians in aged care in different parts of Australia. What's an example, or what are examples of common challenges you see facing service providers?
Thanks, Mel. It can be difficult to identify oral health conditions in our aged care residents, particularly if they're not able to easily communicate their concerns. However, it does mean that some conditions can be left untreated for extended periods of time, and this does greatly impact the capacity for the individual to eat and speak, and they may even have pain. Some of the conditions, and I'll be reiterating what Janet and Nick have mentioned, is ulcers, abscesses, broken dentures, tooth decay and gum disease can all be missed. As you mentioned, I have been fortunate enough to work for rural New South Wales at the public health facilities, and it gave me an opportunity to visit rural residential care centres, and it gave me some insight into the challenges in oral health care for residents. Sometimes the issues actually did have simple solutions, and if there was better access to dental services, it would greatly improve an individual's concerns. So after today, the hope is that there is some clarity in identifying oral health problems, solutions that could be provided at the facility itself, or how to seek help for the resident.
Yeah, we hope so too. You mentioned the difficulty in identifying oral health conditions, particularly where the individual can't easily communicate their concerns, and we see this often in people living with dementia. So I just want to underline what you've said there. For people living with dementia, what impact does this have on their teeth, and how can providers proactively do something about this? Janet, I'm going to ask you this.
Yeah, thanks, Mel. As we all know, cognitive impairment affects the ability of people to be able to often independently care for their general health, but it affects caring for their oral health as well. And it will often mean that when they come into the facility, they have lost that ability to maybe brush at all, but definitely not to be able to brush to the standard that they may have been able to do prior to their cognitive issues developing. So it's very much, dementia impacts very much on their ability to care for their teeth. And the ways that we can manage that for them in the facility are to consider that, of course, the cognitive impairment is having an impact. Also, that they may have some physical impairment as well that is not helping their ability to brush. So for the carers, within the facility and the staff. It's important that that's monitored. And there are a couple of ways that we're able to do that. Initially, it's a really good idea to encourage families to ensure that before residents come into the facility that they have a comprehensive dental examination done with a full examination, x-rays, etc., in the hope that some of that may be able to be managed prior to them coming in. Once they do come into the facility, all residents should be given an oral health risk assessment. Ideally, that should be done by a dental practitioner, so a dentist, an oral health therapist, a dental hygienist, or a dental therapist with adult scope, so that that information can be collected. And then from that oral health risk assessment, then problems can be identified so that we're not failing to detect any sort of mouth issues once the resident comes into the facility. Those oral health risk assessments are really helpful and should be conducted upon entry and every 6 to 12 months. And that really will make a difference in being able to detect common mouth conditions, and then making some effort within an oral health daily care plan to ensure that products or services are put into place to assist that resident with any oral health or dental needs. Accessing oral health services and dental services within the community close to the facility is really important and will absolutely help with this issue.
Yeah, thanks. So interesting. If you're a provider listening and watching, is this on your mind? Do you know which residents have seen a deterioration in their oral health, or who may be seeing a deterioration in their oral health after entering your service? And do you know how each resident is going to access the appropriate advice for them from an oral health or dental practitioner? Just interesting to wonder, and if all these things are happening, then what do you think you can change or do differently? And Nick, I'm wondering if you can help us here. What are some ways staff can detect oral health concerns and prevent that deterioration from happening?
Poor dental health can affect a person's comfort, appearance, eating, nutrition, behaviour and general health. Every person with dementia needs an individualised preventative approach to dental care, and should ideally begin as soon as dementia is diagnosed, prior to it becoming to get more challenging later on. So dementia can cause problems for several reasons. Dementia can cause changes to memory and thinking, which can impact a person's dental care routines. Changes in brain function caused by dementia and many medications can cause a reduction in saliva production. Saliva is essential to maintain a healthy mouth and prevent tooth decay, mouth ulcers and sores, and to make food ready to swallow. So sugar-based medications long-term can lead to tooth decay, the condition of dry mouth, and difficulties using dentures, which is what we see quite regularly. So changes to eating habits, such as replacing main meals with snacks, sucking lollies, or drinking sweetened tea, can cause dental problems. Being proactive and managing the impact dementia can have on oral health includes recognising possible dental problems. Many people with dementia in moderate and advanced care settings are unable to verbally express discomfort or pain. Some stages in behaviour may indicate dental problems such as a loss of appetite or refusing to eat, pulling at or holding their face, refusing oral hygiene care like brushing their teeth, mouth pain caused by dentures that don't fit properly, increased restlessness, disturbed sleep, increased aggression or agitation. So people with dementia frequently suffer from dry mouth. Some medications and products are available that may help. Talk to the doctor or the dental practitioner about these. You can also help the person to drink plenty of water or spray water in their mouth using a spray bottle. 6 monthly dental checkups for those with natural teeth are also important to look after the person's dental health. If the person is eligible for public funded dental care, book an appointment with the dental hospital. They may have staff who specialise in treating people with dementia. many people will want to see the long-term private dentist and are perfectly willing to pay for this, as this has always been done.
Thanks very much. Those are really good practical suggestions for managing dental health care really in residents with dementia. And I wonder how often a mouth issue is considered in a resident who's agitated, and that a consideration that it might be something new happening inside the mouth. I'd really like to hear your thoughts, Janani, on some of the issues to be considered by a provider when arranging a dental or oral health appointment for somebody living with dementia. I'm particularly interested in your thoughts on communication and consent.
Thanks, Mel. It can be slightly complicated when considering communication and consent, but there's a couple of other considerations here as well. So when you are booking a dentist appointment for a resident with dementia, it can be useful to request a morning appointment, especially if the person experiences more difficulty with focusing and communication in the afternoon. If they'd like to have a support person or a family member accompany them, then make sure that's known and try and arrange appointments that suit the support individual. Ensure that the dental clinic and the oral health practitioner are aware of the dementia diagnosis, and that's really important, and making sure they know in advance. And if you can, it can be really helpful to communicate the best ways to support them. So whether that means that they need frequent explanations or reassurance, it'll help the oral health practitioner to give them the best experience possible. Prolonged waiting times should be avoided. So with forward planning, it can be possible to arrange more than just one appointment, particularly if the resident requires treatment. Take through a really thorough medical history and a list of all the medications, vitamins, puffers, anything you know that your resident is taking, and that includes herbal vitamins as well. And let the dentist know so that they're fully informed of the patient's general health. There are lots of interactions, and best to get that entire comprehensive list and send that through to the clinic. And if the treatment does appear urgent, please do make sure that you let the clinic know, because they can make arrangements to see your resident sooner if required. And if treatment is recommended, then please do be aware of who the resident's next of kin might be and who could consent for them if they aren't able to consent for themselves.
Yes, thank you. Earlier, Janet spoke about the role oral health and dental experts play in educating and supporting providers and their staff to identify which person might need what sort of support when it comes to oral care. This is really important for maintaining dignity and supporting self-care, but for some, even more support is needed. For example, where the person may be completely unable to manage their self-care, or where they are unable, for whatever reason, to brush their teeth themselves, even if the toothbrush is put into their hand. So what are some of the ways a resident can be assisted with their oral care, Janani?
I completely understand the challenges in providing oral health care, particularly if the person is unwilling. But if at all possible, then it is imperative to help the resident with their oral hygiene. Brushing, even when performed correctly, is shown to only remove about 60% of bacteria from the mouth. And I'm not going to sit here and say that you need to clean between every single resident's tooth, but if you can help them, use interdental brushes. So they look like little toothpicks with a bottle brush on the end, and they slot in between the teeth and help remove a fair amount of that plaque and food debris. And it can help with preventing decay or establishing or even worsening gum disease. It can help to provide a bit of an explanation and constant reassurance of exactly what you're doing. If the resident is willing to let you brush their teeth, then it can help to use a bite block if they will let you. They're essentially some sponges with a hard interior, and they can help keep the mouth open and support the resident's jaw whilst you do help them brush one half, move it to the other side and then the other. When you are brushing, it is important to use a soft toothbrush with a pea-sized quantity of fluoride toothpaste. and angle the bristles towards the gum line because that's where that plaque is building up, and use slow rotations, ensuring that the brush contacts both the cheek and tongue sides of their teeth. Some residents might be suited to a higher strength toothpaste, and there's different reasons for this. It could be that they have a dry mouth and lower salivary flow, but that could be just guided by the dentist or the oral health practitioner that's seeing the resident. And as I mentioned, cleaning between teeth can be harder to achieve. Using floss is likely to be really difficult. So if possible, using interdental brushes, if you've tried them, please give them a go. They do come in different sizes, and they're quite effective in cleaning between teeth. And if a resident does have a significant level of fluid or plaque present, if they're able to, it can help to rinse their mouths before brushing, and that can help remove a lot of those bugs that need to be brushed away.
Yes, thank you. Certainly also remember that family carers, when somebody's new to residential care, may well be able to give you some pointers about what works well to assist their particular person. But Nick, can you give us some advice on caring for a person with dentures, or somebody who is edentulous, which means somebody with no teeth at all?
So as you'll see on the slide in front of you, the big thing is about removing the dentures. So for any carers in the aged care facilities, it's important to take your care when you remove the dentures. Always wear gloves. Now, the dentures will be slippery, so be very, very careful to have a nice firm grip. Grab the denture at the front, and with your spare or your free hand, move the patient's lips or cheeks out of the way, and you can remove the denture that way. Just be careful where you're removing it. If the patient is bed-bound, it's okay, because if it does fall, it's less likely to break. If you are in a bathroom or have a hard surface around you, just be careful not to drop the denture, because they are plastic at the end of the day. Putting the dentures in, again, gloved hand, firm grip. With the upper dentures, I tend to approach the patient from behind and bring the denture around to the front of their mouth. With my left hand, because I'm right-handed, I move their lips out of the way and I rotate the denture into the mouth. So again, you can see on the slide there that rotation. If the patient has a small mouth or they have sores in the corners of their mouth, it's a good idea to use a little bit of Vaseline to make it easier. Or you can see in the image there, using a toothbrush instead of a finger to move the cheeks or the lips out of the way. For a lower denture, much the same, gloved hand again, but I approach the patient's front on as opposed to coming from behind. Move the lips out of the way, rotate the denture in again, don't try and put it in front on. And in some circumstances, it's advised to ask the patient to raise their tongue while you pop the denture in to make sure the tongue's clear and doesn't get caught under the denture.
And Nick, how then do you know if somebody's dentures aren't fitting properly, and what can be done about that?
So there's a couple of key things. Generally, when you're speaking to somebody, you'll see their dentures moving around if they're very ill-fitting. As a patient smiles, the dentures will drop. If you watch a patient eat, and you'll see that they end up eating more dentures than they do their own food, you'll tell that they're quite loose. This is all just visible checks as opposed to anything involving actually feeling the dentures. If you were to have a gloved hand and put your hands inside the patient's mouth and press the dentures down into the tissue, if the dentures basically spin sideways, you'll tell that they're very loose and in need of urgent attention. What I generally suggest to patients in aged care facilities as the first step is to use a denture adhesive. Example is something like Hold Tight. There's Polydent, there's a whole range out there. They are very good at keeping the dentures in place, provided the patient has enough saliva. That is just a sort of a stopgap until you get in touch with a dental professional. So we don't advise to just use denture glue. We do say that there's a reason why it's needed, but the denture is obviously not fitting. So if the teeth are in good condition, it's just the patient's mouth has changed shape too much that the denture doesn't fit, a reline is probably what's required, which is making a new fitting surface to make the denture fit again.
And while I've got you, what about the current recommendations for care of dentures? How do you manage and review and maybe replace them if necessary? I don't mean replace them in the mouth. I mean replace them if they're gone or
Yes.
not worth keeping.
Yeah. So from a care perspective, there's quite a few steps. Dentures should be brushed and cleaned daily. What we recommend is if a patient has dementia, to break the steps down into smaller steps to make it easier for them to recall. If the person's unable to look after their dentures independently and you're assisting, what we suggest is to be very careful when you clean them. So we did talk about gloved hands and slippery dentures. When you're cleaning, if you are cleaning over a sink, to put a towel around the rim of the sink, or a tea towel or anything like that, if in case you drop it onto the porcelain, and to put a little bit of water in the sink. So the key thing here is with cleaning is do not use toothpaste. Toothpaste is designed for teeth, not for dentures. If it's too abrasive, it'll scratch the acrylic. It eventually attracts more bugs to the denture, and that forms into calculus and staining, and it's very bad for the patient's condition. So a great bit of practice is after every meal to rinse the dentures and rinse the mouth, and then thoroughly brush them with a denture brush. We have a denture brush here for an example. Something like that is fantastic. And using just plain soap and water. So that works really well. At night time, we don't follow what we used to do. We always used to put them in a glass of water beside the bed. So we don't do that anymore. We clean the dentures, we dry them, and we put them into a denture box or a denture container like so. And then until the morning, they're removed from the box, they're wet, just under a bit of running water, and they're popped back into the mouth. If the patient has been using a denture adhesive, it's important to remove the adhesive during the cleaning process from the denture and also from the patient's mouth. Exfoliating gloves are very good because they stick to the adhesive as you remove it. Otherwise, it's like chewing gum, trying to get rid of it. Cleaning the dentures regularly with a specifically formulated denture cleanser, something like Caldent, Polydent, Sterident. There's a whole range of them on the market. They will vary as to how frequently you use them. Caldent, for example, is once a week. There are instructions on them how to use them. I normally suggest to people, if you notice the denture staining more regularly, use the denture cleanser more frequently. Be very mindful of patients who wear partial dentures. A partial denture is someone who's only missing a few teeth. They have little metal clips on them. You need to be careful of the clips not to be bent, not to be damaged. That also means when you're removing or inserting the denture, be careful of the clips. And when you're cleaning, you should be cleaning around the denture thoroughly, including the clips. If the person is living in a residential care, dentures should be marked for identification. So I've done one here for you, just for an example. Put my name inside the denture there. What that does is a lot of people will look at dentures and they all look the same. It's very important that we can tell if it's Mrs. Jones or Mr. Jones whose teeth they actually belong to. In the later stages of dementia, it may not be possible for a person to wear their dentures, so we need to keep that in mind. And booking in a regular professional denture clean can also be an excellent way to maintain the health of the mouth and the health of the dentures, meaning we'll get the full use of them. So this process should be undertaken if the patient is unable to clean their dentures thoroughly. Prosthetists can do this. I'm sure dentists can do this as well. And it should be done, I recommend, about every 6 months, but it does depend on the state of the dentures. It's very much a case-by-case situation. So if we're noticing that the teeth have severely worn, they're chipped, they're fractured, get in touch with a dental professional to have an assessment made about replacing the dentures.
Yes, thank you. It's more complicated than you might imagine if you've never had to care for dentures. So this is an area that staff may well need a little bit of guidance on. But one thing that stood out to me, and I'm aware that many people still keep their dentures in water overnight. So Janani, I wonder if you can help explain why this guideline has changed.
Yes, absolutely. So when it comes to dentures, it's really important not to leave them soaking in water overnight. Bacteria and yeast love wet environments and they will thrive on the water and grow. And it's a similar situation if residents leave their dentures in whilst sleeping. Not only are they providing a moist environment, it's also warm and there's less access to oxygen. It's ideal for bacteria and fungi to grow, and the greater quantities of resulting fungi will generate a condition known as denture stomatitis. It's a specific form of fungal infection, so essentially thrush in the mouth. It follows the outline of the dentures, and initially it presents as a really bright red lesion, and it doesn't cause pain initially, but over time it can swell and ulcerate and make the underlying gums really spongy. And that's going to cause pain, but it's also going to affect the way that the resident's dentures seat, not only at present, but also in future cases of when they need new dentures. When talking to patients, I usually use the anecdote of it being similar to keeping their socks on all the time. So eventually when they do remove their socks, they're going to imagine how uncomfortable and their skin's going to feel. And that's exactly what's happening in the mouth and the gums there.
Thanks very much. And if I could just throw in one of my own anecdotes, because it came to me painfully late in my career to understand that when people are aspirating small or even large amounts of saliva and food and fluid, that what is in that they aspirate, the dirtier the mouth is, the more germs they're aspirating, and the much more likely they are for that to turn into an infection or pneumonia in the chest. So that's not instantly understood, I think, as a risk factor for aspiration pneumonia. So thanks for highlighting that again, all of you, and thanks very much for that. Janet, I'm going to hand back to you now.
Wonderful. Wow. There has been so much information conveyed in that panel discussion. If you're anything like me, taking notes furiously and making a mental note to go back and check the recording because I want to listen again to some of that detail. Thank you so much, Janet, Janani, Nick and Melanie for a very engaging, informative discussion. We do now have time for questions, and we have received some prior to the webinar and indeed some coming through during that conversation. Please keep them coming. But I want to open this part of the webinar with a consideration of end-of-life care, and in particular palliative care. We've heard a fair bit about people living with dementia and the particular challenges that they may experience, certainly in self-care, but possibly also to those who would be responsible for assisting them with oral hygiene. Melanie, I want to start with you, but I suspect we might then move to Janet. Can you just give us an opening framing of this question of people moving through end-of-life care and in the palliative phase of their care experience, and what are some of the issues? And then, by all means, throw to Janet to provide her perspective as well.
Yes, I think Janet will be able to give some much more specific, helpful advice than me. But the issues when somebody's really in the very end stage of their life and moving towards their death, the goals of care and what the person wants for themselves, if they've got an advanced care plan, will usually be to do anything possible to keep me comfortable. Mm-hmm. And as you progress towards death, there are many things that happen that may or may not contribute to that discomfort. So it's really important to be aware of them in advance. But a really big issue is mouth. So mouth comfort can really be affected at the end of life by whatever's happening to you as you are dying, and that would include such things as hydration. When you see people not really closing their mouth, so there's much more mouth breathing happening, and in some people there is more secretions happening and various infections occurring in places where you need to manage the symptoms. And I think that Janet Wallace, you will definitely have some tips on how to go about managing some of those issues to keep people comfortable rather than being in a preventive space.
Yeah, thank you, Mel. I think this is one of those situations, again, where it's really important to have a dental practitioner come in and provide some advice to the facility staff when we're dealing with people who need palliative care. In the resources we've developed and many of the websites we've provided, you will also be able to access some of that information. And I think looking at the resident holistically and bringing in a speech therapist, a dental practitioner, to give some advice is also really very relevant. As Mel said, it's really at this stage of life where comfort is what is most important, comfort and pain. And really it's about ensuring that that resident has got some hydration and that their mouth is moist and that any bacteria, debris, food is not stuck in their mouth. And unfortunately what happens at this stage of life is that often debris collects in the palate and underneath soft tissues, and that can make their mouths very, very sore, but also it's a choking risk as well. So ensuring that there is nothing stuck anywhere in the resident's mouth is very important, especially if they're not conscious. Getting that out is not easy, and things like very, very, very soft bristled toothbrushes can be used, especially if they're put into warm water so the bristles are made even softer. Warm, wet gauze. Please do not use those sponges on sticks because they have been known to lodge in the resident's mouth and cause choking and death. So please do not use those at all. But keeping the resident's mouth moist, you can use water sprays. You can ensure that the resident's mouth and their lips are sprayed with water every 30 minutes. There are also loads of products, loads of great products, which I won't name them by brand, but there are lots of really great products that are made specifically to aid xerostomia dry mouth, and they are great in palliative care. So they can be sprayed into the resident's mouth on a regular basis, on the roof of their mouth, on their tongue, and they do work really, really well. If the resident is conscious, you can also consider using ice drops every hour, giving them some ice drops to make sure that their mouth is moist. But I just would like to again reiterate that at this stage in life, again, it's really important to work with your dental practitioners to get some other advice, because the resident may have other issues in their mouth that are causing them excruciating pain that they can't obviously tell you about, and there may be something else that could be suggested. So rather than going through all those things with you, I would rather just say to you, please ensure that the resident is provided with holistic care, and that means that a dental practitioner, a dentist, an oral health therapist, a dental hygienist, a dental prosthetist, a dental therapist is called in to consult with, to have some input in that area. It's a very, very sad period of one's life, but we want to make sure that those residents are supported so that their mouths are as comfortable as possible. And we also want to make sure that we are helping their families help them as well at that last stage. Sorry, Mel, I probably went on a bit of a rant there, but I hope I've covered it.
But thank you. Your last point is actually really important, because it's something that families can easily be taught to do and enabled to do, and it, in my experience, gives them a really positive role while they're, to really contribute meaningfully to the comfort of the person if they're sitting beside their bedside at that time of life. So thanks for that, Janet.
Thanks,
okay. We've had a very high level of interest, Nick, in your exceptionally practical outline of denture care. There are a number of people who've asked the essentially practical question: how did you label the denture? Did you use the normal label from label maker, or did you use some other means? Very keen to understand that. So clearly there are a lot of people online who are concerned that they're not labelling effectively, and would like your tips on that, please.
Yeah, of course. So that particular one that I showed you, I've used a label maker and then I put a clear acrylic over the top. So unfortunately, you can't just stick a label maker on top without putting the clear acrylic. So that's only practical if you're taking it to a dental technician or prosthetist, or you take it to your local dentist who uses their technician to do so. From a more practical setting, there are kits that you can buy online which you can scratch away a bit of the acrylic, put the patient's initials or full name or whatever you wish, and then you can paint a coating over the top, which will mean that the name won't wear away. So if you just typed in online Denture ID or Denture label maker, there are a whole heap of brands in Australia that you can actually purchase. They come as a kit that you can do 50 odd labels. So very helpful for aged care facilities to purchase a kit themselves if they want to do it in-house. It'd be a lot cheaper, a lot easier. Or if not, by all means, speak to your dental practitioner or denture professional and have a chat about options that way as well.
Brilliant. Thank you very much. I'm quite sure a lot of people are going to go away and do some further research as a result of that advice. Well done. I'm not sure whether this is for you, Janani. Thoughts on electric toothbrushes? Can they be better than regular toothbrushes?
Yeah, happy to respond to that. Absolutely. I think the most fundamental thing here, and I say this to patients all the time, is it doesn't matter what type of toothbrush is utilised. It's more about the technique, where it's positioned, and whether it's doing a sufficient job in removing that bacteria. Now, I understand that electric toothbrushes might be a little bit easier when it comes to dexterity because it's going to do those rotations for you, but it is still important to know that it is positioned in the right area. So it needs to still be angled towards that gum line in order for it to be effective. If you are going to use a manual toothbrush, as Janet mentioned before, it absolutely must be a soft toothbrush. And the other added benefit of if an electric toothbrush is utilised is that some of them do have a pressure sensor, so they are able to inform whoever's using them that you need to be a little bit more conscious of how hard you're pressing with your brush. But at the end of the day, whatever is utilised, it's just got to be the right technique.
All right. Well, seeing as how I have you on screen, or had you on screen, with your mic open, I had another one for you. A question about milk or other dairy. Are they beneficial to mouth care?
Yes, absolutely. And it's more in the milk proteins. So milk contains casein and also can contain lactoferrin. And those milk proteins have been shown to limit the action of bad bacteria in the mouth that normally contributes to tooth decay. But it also has widespread benefits with studies showing that they can be antibacterial and even antiviral. Teeth are formed from a compound called hydroxyapatite. Don't need to remember the name. It's more just the fact that it contains calcium and phosphate. And calcium, it's in milk, so it's fairly easy to understand then that it can be incorporated into the tooth structure and help with acid attack and remineralizing the tooth. Following those benefits, there is actually a product called Tooth Mousse, which utilizes the casein. It comes in two forms. It comes with and without fluoride. The reason I'm mentioning this product is that it provides a saturation of calcium and phosphate onto the tooth surfaces, and it can help if residents are lacking saliva flow and if they don't have those benefits from normal action of saliva. It is an over-the-counter product, but I would ensure that you do have advice from your oral health practitioner in whether or not it is actually going to help your resident, and please do make sure that they do not have a milk protein allergy.
Good tip. All right, there's one more for you, and then I've got one for you, Nick, about differences between implants and dentures. But Janani, elective tooth extraction. There's a question about contemplating when or whether that is ever an alternative which should be considered to facilitate care for an individual as they move through their residential care experience.
I feel that it was very much a historic thing that was done. I do have discussions with patients when for their 21st birthday they had all their teeth removed and had dentures put in, and then that was just commonplace. Now, there's very many factors that are involved in this question, but I do like to tell people that when it comes to loading your teeth, so with your chewing and such, your natural teeth can take on a load of approximately 22 kilograms. Once you have dentures in, that's going to drop down to 8 kilograms, if even that. So you can see that there's this massive fall in the level of functionality that you're able to have. And with this question, there's a lot of factors to consider, and ideally your resident is going to have had a comprehensive oral health care check done prior to entering the facility, as Janet had mentioned earlier. Whilst I agree that it can be challenging to reach posterior teeth when caring for a resident, we must consider the importance of having your posterior dentition, and that is in numerous ways. And it's the main teeth for chewing force. They might be supporting a resident's denture, but also it provides your face with height. And this is really important because with reduced height, there's going to be more folding around the lips, and that's actually going to cause a condition called angular colitis. It is a very irritating and painful condition in which we've got bacteria and candida that build up into the folds of the mouth, and your resident's going to require steroid cream to treat it, and that might even be a long-term requirement. So in order to avoid all those, it's a consideration to try and keep the posterior teeth, absolutely. But in saying that, I will mention that there are some conditions or states when the back teeth might need to be removed, and that is if a resident only has one or two, and there's numerous large spaces around. Now, having only one or two back teeth is actually not going to be helping the resident all that much. They might actually be better off having a full plate in that instance. So it's a very loaded question. There's a lot of things to think about. And again, I just reiterate that it's best for that resident to go in and have a dental checkup done, so that all of these considerations could be put into place and the best advice can be given for that individual case.
Wonderful, thank you. Nick, dentures versus implants, I'm wondering whether they present different responsibilities or opportunities for aged care staff who are supporting an individual's oral health care.
Yes, so dentures versus implants, you've got to understand that dentures are going to be removable. So they can be removed from the patient's mouth, they can be cleaned, then the patient's mouth can be cleaned separately. Right. Implants themselves are going to be fixed to the bone. So whether we're talking implants with individual teeth, so crowns on top, or a bridge, a series of crowns, or we're talking about implants that have a denture that sits over the top. So there's a couple of variations there. Implants themselves, we generally suggest to patients to maintain them as they would their own natural teeth, or actually increase the hygiene. So keeping the implant itself clean is very, very important. Keeping the tooth structure and the tissue structure around the implant, if it's a crown, if it's a denture, removing the denture and keeping the implant clean is vital to make sure that the implant does keep its structure and is utilised for the patient. So this harks back to Janani and also Janet's conversation before about having dentist checkup appointments every 6 months and making sure that those implants are sound and they're not gathering bacteria around them and they're causing issues down the track for the patient.
Okay. Melanie, last question to you. If accessing a dental practitioner is going to take some time or prove to be challenging, I'm assuming that fundamentally there are a set of things that we're expecting personal care workers to be able to do to support an individual maintain oral hygiene. We don't have long, but just can you reflect on that for a minute or so?
Yes, and we do go into that a little bit in our resources, really just trying to enable people to at least have a basic think about the mouth and look at the mouth and identify when there may be a problem, even if they can't identify what that actual problem is. And of course, the impact on the person would need to be considered when you're trying to prioritise. So if you're trying to access dental or oral health care and it's challenging, you would probably need to be knowing when it's something that you need to be presenting and promoting and advocating for someone as urgent. So I think that bearing in mind some of those things will probably help with that, help with early detection so that it's not yet urgent, and also help with identifying when something might need a rapid escalation. And if you're in an area where you are having challenges accessing this help, it's probably something that you should actually actively engage with your local health service, trying to identify what practitioner support there is, and having a conversation with them about how they could possibly help you when you may not even know they exist in your area. But obviously, if something is clearly a problem and it's stopping someone eating, then urgent action would need to be taken, or if it's causing a lot of distress. And hospitals have a role here as well. If you're unable to get someone to see an oral health practitioner in a timely way, and the person's at risk in some way for their health.
Thank you, Melanie. All right, that brings us to an end of the webinar. My thanks again to everyone who participated in the panel session. It really has been a highly informative webinar as far as I'm concerned. We do have in the next slide a survey, which I would encourage you again to complete, please. You will also get access to, via a link, a goal planning template, which you can download and use to help improve your service. If you have any suggestions about the ways in which any residential service can improve food, nutrition and dining, please drop us a line, get in touch and let us know. It may be something you've done or that you've heard somebody else has done with great success. And I do encourage you to stay up to date with the resources that we are publishing. We've talked about them in the course of the webinar, and you will find them on our website. So please drop into the website and have a look. And if you find something that's useful, let your friends know and share it around a bit. Thank you, everyone, for participating in this webinar. Really appreciate your attention, and we look forward to further engagement. Take care. Bye-bye.